speaking of stubborn, the containment numbers related to the transmission of COVID continue to be stubborn here in the state. And that's why it is important just to remind each and every one of you of what you already know, and that is COVID-19 will be with us for a long time, and we need to adapt. This idea that it was going to go away in the summer, during the warmer months, that somehow it would disappear based upon an assertion, a tweet, or a headline has obviously been substituted by a different reality that not only we're experiencing here in the state of California, but all across the nation. And so it's a sober reminder that what we will be announcing today in terms of our progress and in terms of our new strategies in terms of how we begin to modify our stay-at-home order, that we must deal with this reality and live with this fundamental truth until there is a vaccine, until we have the kind of therapeutics that could substantially mitigate the spread and the impact of COVID-19, that we will simply need to adapt our behaviors until that time. We've learned a lot over the course of the last number of months on how this virus spreads. A lot of focus on moving activities to the extent possible from indoors to outdoors as a significant contributor to mitigating the spread of this virus, the importance of face coverings, the importance of masks, physical distancing, avoiding out of your household cohort, the kind of mixing, all of those things we've learned with a greater sense of understanding, capacity that we're trying to bring in to an adjustment that we'll be making to our sector framework. For the last few weeks, we've been previewing that we wanted to make adjustments based upon the input we received from county health officers, input we received from experts, our own experience here in the state of California, to adjust the frameworks from the old monitoring list to a more dynamic list that we hope is not only more dynamic, but is much more simple to understand. Stringent, no, nonetheless, in terms of its application, but statewide in terms of its consequence, in terms of what it covers. Simple, also slow, and I'll get to that as we look to a blueprint for safely reopening the economy, pulling in the lessons learned, pulling in our own experience, others' experiences, lessons learned in other states and across the country. These are the guidelines that foundationally we are advancing as it relates to this new blueprint. We're looking now to a uniform framework, one that provides 4 tiers. You'll be now hearing a lot about tiers, 4 tiers. There are colors attached to that. We'll get to that in a moment. 4 tiers, not 58 county variations as we've seen in the past. Process not only for tightening these restrictions, but also loosening these restrictions now are based upon these same metrics. The metrics that we assert are the most significant in terms of giving us a leading indicator of how things are taking shape in a particular part of the state are case rates and test positivity rates. Case rates, number of individuals per population cohort, be it 1,000 or 100,000 that test positive, the percentage of people that get a test that test positive, the positivity rate. So case rate and test positivity will be the new simple metrics that will determine movement within these tiers that we will be highlighting here today. There's also, and Dr. Galley will be highlighting this, an additional health equity consideration. He can talk more about what we're exploring in that space, but that's foundational. Again, always looking at the lens of equity as it relates to the work being done to test cohorts, populations, essential workers, but vulnerable workers and vulnerable communities, low-income communities and otherwise. It is critical that we're doing justice as it relates to the kind of testing we're doing, the specificity and targeted communities that we're testing, because we don't want to see people game these numbers. Here's what we're looking at. We're looking at these 4 tiers, color-coded, making it a little simpler for folks, purple, red, orange, and yellow. We don't put up green because we don't believe that there is a green light that just says go back to the way things were or back to the pre-pandemic mindset. Quite the contrary. These are the guidelines, these color-coded county guidelines that we're putting forward to get us through this flu season, to prepare for the upcoming flu season, this twindemic as sorts, as we deal with flu and we deal with COVID-19, to work through the next few months here in the state of California. Again, this is a dynamic process. It's an iterative process. We are not stubborn in terms of an ideological thrust. It's the work we're doing and the considerations that we make in real time with experts and county health officers and members of respected industries and members of the public that provide guidance and feedback. But the guidance and feedback we have received that helped us put this in place, we have and advanced and engaging in seeking that guidance and collecting that guidance over the course of many, many weeks to put together the chart that you see in front of us. The purple part of this, the risk level, we refer to as the county risk level as widespread, is what commonly was referred to in the past as the old monitoring list, the old watch list that you may have seen in the past. Let me give you an example. We had 34 counties that were on the old monitoring list, the old watch list. Now, that list, broadly defined, and I'll be specific about the distinctions, is defined now in this purple category as the widespread as it relates to the impact, the community spread, the background spread of the COVID-19 virus. New cases that are more than 7 per 100,000, which, by the way, that's a daily case rate. It works out to be roughly exactly the old case rate of 100 per 100,000 we had for a 14-day period, 98. So that's what the 7 represents. We just want more specificity, looking at daily rates, not just that 14-day rate. So no more, or rather more than 7 rates, new cases per 100,000 population, and those with positivity rates north of 8%. You'll see where the state of California is. We're closer to 6% over the last 2-week period. But if you're in a county with more than 8%, you would be on that purple list. If you have a number of new cases that are more than 7 per 100,000 population, you would remain on that purple tiered list. Dr. Galley will come up in a moment and say what that means from a sectoral perspective, what that means from guidelines as it relates to individual cohorting, group cohorting, the expectations, rather, we have in terms of individual and group behavior. But let me quickly go through just some of these other colors before I bring up Dr. Galley. So the purple representing what broadly was defined as the old watch list. The new sectors, now 3 tiers, as we refer to them in these new guidelines. The red tier is substantial spread. That's reflected 4 to 7 cases, new cases per 100,000, and positivity rates that drop below 8% and put us above 5%, so 5 to 8%. The moderate represented in orange, and there are a number of counties in that category today. I'll provide that list in just a moment. Those are with new cases, case rates below 4 per 100,000, 1 to 3.9, and you see positivity rates that get up to 4.9%, below 5%. And then, of course, minimal, that's the category, this yellow category. We have less than 1 new case per 100,000 and less than 2% of people that are test positive for COVID-19. As you can see with these purple, again, we are replacing the old county monitoring list, and we have criteria and expectations. It's sort of a reset. The counties that start in the higher tiers, higher than that purple tier, have to be in that tier with criteria within that tier that have met for at least 2 weeks. One thing we've learned from the previous reopening experience, something I'm asked all the time about what is the experience you had in the past, what are you incorporating in terms of new considerations in this new approach. One of the things is making sure that we really hold strongly to these buffers in terms of criteria and data, and holding that criteria and data in line for an extended period of time. You'll see here in a moment, we want to extend that period of time even beyond 2 weeks as it relates to people moving into new tiers. But you at least have to have stability for 2 weeks, and we'll talk more specifically about, again, what that looks like. We're going to begin our new assessments on a weekly basis every Tuesday, and we'll be updating every Tuesday the county monitoring list as we go. Here's our snapshot where we are today. Number of counties, again, represented in purple, 38 counties, red counties, and orange, you see 9 and 8 respectively. Yellow counties, the minimal is represented by 3 specific counties. So again, 38's roughly in that range, 34 the last time. Remember, counties come on and come off the old monitoring list, roughly about the same number of counties. With the new criteria, we capture a few counties that were just coming off. They're likely to come out very, very shortly, and you'll see that update in a moment. We, again, expect this to be a dynamic list and continue to see people move into different tiers and certainly move into a different mindset in terms of how we can approach a lot of the activities within the respective counties. 87% rather, of people living in the state of California are living in these purple counties. Again, 38 counties representing about 87% of the population, 12% in red, 1% in orange, 0.1% in yellow. So you get a sense of how stubborn this process is, why we say statewide, stringent, but we also say slow in terms of our ability to move into these different tiers. Again, here are the tiers in the represented colors, and in each tier, in order to move out of those tiers, there's now a 21-day mandatory wait time, 21 days. When we did this the last time, Dr. Galley will talk a little bit more specifically about our experience in terms of the health orders we put out. We put out guidelines. They didn't mean go, but we empowered the counties to make decisions based upon attestations and partnerships that had to form with county health officers signing off with county officials on their ability to move. We're going to be more stubborn this time and have a mandatory wait time between moves. We didn't do that last time, and that is a significant distinction between what we've learned from the past and what we now are advancing in this more stringent, but we believe more steady approach to moving counties within tiers and modifying the activities within those respective counties. We also have a criteria, not just 21 days on moves between tiers, but also 2 weeks of some stability and steadiness before you move into those tiers, as well as a recognition that every week we'll continue to assess and we'll update the EPI criteria, the EPI data, the epidemiological data, so that we're sharing it with you, the public, sharing it with the county, and you'll see in a moment a new website and a much more dynamic, we hope much easier website in terms of accessing information, providing, we hope, more transparency in this space. Again, because you may have seen this for the first time, this may not be as easy to understand, perhaps, as the old watch list, but the purpose, our emphasis in terms of how we're approaching this is we believe this is much more simple, much more transparent, easily monitored by individuals, not just by business representatives, but also by county and state health officers. We have a criteria that also toggles forward, but also toggles back. Moving back, if you fail to meet the criteria for at least 2 straight weeks, you'll have to move back into the old tier. And Dr. Galley, in just a brief moment, will come up and talk about this emergency break we have, because we're not completely abandoning this notion of ICU capacity, hospitalization capacity, the other criteria that is very, very important. No one is denying the importance of that criteria. We're just not leading with that criteria. We're leading with case rates, and we're leading with positivity rates as the 2 leading indicators, as a simple measure to move within tiers. But again, the ability in real time to address criteria of conditions that may radically change in one county or another and various factors. We also have proposals and processes in place where we have this so-called emergency breaks, again, like things that include hospitalizations. I want to provide this slide as an introduction to Dr. Galley. He'll explain what's on this slide, the 3,142 and the date that's attached to that and the current number of a little over 4,200 and what it represents today. You see it's number of positive COVID patients within our hospital systems. It's a sober reminder of what we are announcing today and what we're not announcing today. We just want to put up clarity, or rather slides for clarity, guidelines that provide a little bit more clarity to you of the kind of conversations we've been having for weeks and weeks and weeks with local health officers, but also within this frame, some clarity to the business sector. But again, it is driven fundamentally, all of this, very soberly, by what's happening in our hospital system, what's happening in our ICUs, what's happening, as they say, on the ground, real life criteria, real life considerations. And I want to bring up Dr. Galley to talk a little bit more about that. He's going to introduce a new website that we hope you use on the COVID-19 site, a much more updated, we hope more dynamic and iterative website. And then I'll come back and talk a little bit more about additional strategies to strengthen our efforts as we move forward to make sure we're much more, again, stringent and incorporate some of the lessons learned from our previous experience around these modifications. With that, Dr. Galley.